Our project was to reduce the time it takes to get an appointment in a primary care physician's office in the physician's network. This is a critical effort to help the primary care physicians become more competitive in the community, and it'll improve the patient satisfaction scores and improve their image in the community, and help us become certified in the NCQA's patient-centered medical home, and ultimately improve our production. So without further ado, I'll let Carla, Suzanne, and Ash go through things.
I'm Carla Church, family practitioner here in town. So, why should you listen today? Ultimately, patient access is a problem across the board. It's huge. The patient-centered medical home and all of these concepts are huge right now in the movements and the new waves of change coming about in medicine. So we find that clinics are turning patients away, and it's decreasing continuity of care, decreasing the financial gain of having that patient stay within your network, yet this is a must-pass for PCMH, which is Patient-Centered Medical Home, for that certification. And our goal is for all clinics to be certified. I think it's by 2016. So this is also a question on the CG caps. So this is a questionnaire that for the ambulatory setting, our patients get this every quarter. And so this is 2014 data, but you can see that in the past 12 months when you phoned your provider's office to get an appointment, how soon were you able to, or were you able to get this when you wanted? So this is last year's data. As you can see, some clinics are better than others, but ultimately there's room for improvement. It is a true problem. It's something we really need to address.
So to establish the actual problem, what we did was we surveyed the collaborative, which is a group of CHI clinics, primary care. We surveyed 8 of these clinics. The questionnaire was essentially eliciting their knowledge and attitudes about the third next available. And these are just some of the main points about our survey and the methodology. We sampled 8 different clinics. We used a composite indicator, and essentially our questions were pertaining to third next available and allied concepts. So, and we'll come back and define what's third next available, but essentially we were trying to get an impression of how much do these clinics know and what's the variability in their knowledge and practicing attitudes. So this is essentially the knowledge and attitudes. The range of scores was anywhere from 0 to 25. There were 8 questions pertaining to the concepts related to third next available, and 1 question simply eliciting what's the ideal number to third next available. So essentially the maximum score could be 25, and one of the clinics was very close to it right at the start. But as you see, there's scores all over the board. From as low as close to 15 and then as high as 24. And then after, this was at the initial meeting of the collaborative, and once we had started educating them and providing information on the third next available and giving them a little bit more insight into what the concept entails, how it can affect productivity, and essentially how it improves healthcare delivery, we went back and did the second wave survey. And it showed us some improvements in some of the parameters. It was a very short span, and third next available is a concept that clinics across the nation have been trying to improve these numbers. So I think in the short run, our team produced some good numbers. So for example, the mean awareness in these clinics with regards to the third next available, the mean score went up from 1.5 to 2.3. The awareness regarding the panel size and practice scope and the concept of team huddle, all of which are concepts that tie into the third next available, both of those went up. And then 65% of the respondents were better able to identify the ideal number to third next available, as opposed to 40% at the initial survey. So I think compared to the pre and post assessment, we showed some movement towards a better knowledge and more positive attitudes toward this concept of third next available. I'll give back to Carla.
So that shows how important education is. So that helped us with our project. So our project passion statement is that compassion compels us to see patients when they want to be seen. The big picture vision is that we want that third next available to be, that appointment time to be 0 days for primary care. And the project vision, we wanted to be able to develop and demonstrate a strategy to do so just in one practice. So I want everybody to introduce themselves. Again, I'm Carla Church, just so you know who all of us are.
Ashutosh Attri.
I'm Suzanne Vandenhall. I'm a family physician at Antelope Creek.
Steve Martin.
Salam Salman.
It was a pleasure working with all of these guys.
And Jenny did arrive.
Yes. Yeah, there she is. So, so again, the scope of our practice is smaller, making it more manageable. So, an acute visit in a specific clinic for an established patient. So this isn't a physical, this isn't a med check. This is a patient who's already established with an acute, I'm sick, I want to be seen visit. And the deliverable was a best practice to drive third next available to 0 because this assesses access. And access is honestly one of the most important things for, you'll see all the benefits, but for finances, for satisfaction, it's access. So our project benefits is that more patients will get the appointment time they desire. So as you can anticipate, it's going to increase patient satisfaction, increase CHI revenue. A patient doesn't go elsewhere. They don't go to the ER, which drives down cost. They may develop a higher affinity to our hospital. Also, it'll increase quality and continuity of care, and that CG CAP score hopefully will improve as well. So the ominous third next available, what does this mean? You know, we throw around this term, but to have a definition, and it takes a while to grasp it. But imagine you have a cold, and you call to get in to see your doctor. And the scheduler says, oh, well, they have an appointment here at 10 a.m. You say, I can't do that. Okay, we have 11:30. No, I can't do that either. And that third next spot they offer you needs to be within 24 hours of you calling. So say you call at 4 p.m. on a Thursday. Within 24 hours, there should be 3 spots of options for an acute visit for an established patient in a primary care office. I'll let Suzanne discuss some aspects for you.
So the best way to achieve that third next available appointment down to 0 is to make sure that that office is as efficient as possible. And through a lot of different research, we found 6 specific ways to improve efficiency in the office. One is the pre-visit planning. If you plan for the patient before they actually show up for the appointment, it makes things so much quicker when the patient does show up. It ensures that your tests are on time. It makes sure that the tests are available from previous. There's been times when I've had patients come in, I see them and I say, let's send you to the specialist, and then I want to see you back after that appointment with the specialist. Well, in the old world, that patient would show up and I'd get ready to walk in the room and go, oh my gosh, I don't have the report back from that specialist. And then I'd have to turn around, I'd have to talk to someone, we'd have to try and find that report. The patient would be waiting there. I would not be efficient at all. It would slow everything down. This also shows the patient now in this world that we're competent. I walk in, I've got everything ready, I know exactly what I need, and the patient is impressed at how efficient we are. Now, the pre-visit planning, there's that word you heard earlier, the huddle. This is something that the patient care team does the day before the appointment. So, like this morning, I met with my nurse and I met with our scheduler, and I looked at Friday's schedule. And I said, okay, these patients are scheduled to come in. Let's make sure that they're coming in at the appropriate time. There have been times I've had kids come in for a 6-month well child check, and it was 2 days too early for them to get their shots. And that is so frustrating to a mom to come in, bring their child in, and then have to turn around and come back in 2 days later, a week later to get the shots. It's so much nicer if you can do all of it at that same visit. So we check for those things. We check to make sure that, okay, this 61-year-old patients coming in, and when was their last colonoscopy? If we don't have one on there, we hunt down their report. If they haven't had one done, we get all our ducks in a line so that when they walk in, I just say, hello, good morning. You know, we realize that you haven't had a colonoscopy and we've been trying to talk to you about this. Are you ready to schedule that now? We get those things ordered. And another great way for pre-visit planning is when I have a patient come in, I get labs on them that day while they're there. When I verify those labs, I say, okay, their A1C was great. Let's recheck it again in 3 months. Their hemoglobin or their lipids were really good. Let's recheck that again in 6 months. And their thyroid level, good. We'll recheck that in a year. As soon as I verify those labs, I also put the order into the computer for when the next labs are due. That saves me a ton of time, and it makes sure that I don't miss any of those tests. Now, practicing at the top of one's license is also extremely important in helping with efficiency and getting that third next available down to 0. There's only one person in that patient care team that can see the patient, examine the patient, diagnose the patient, and treat the patient. And if I, as the doctor, am busy sending out orders, trying to get patients set up with specialists, filling out forms for mammograms, trying to find results, that really slows me down and takes time away from me seeing those patients. If I delegate that task and that responsibility to someone else in the patient care, it helps with efficiency. And I can tell you from experience, my nurse is so much better at catching to make sure that those people who need a colonoscopy get it ordered than I am. And if I write up protocols for all my patients with diabetes, or all my women over 40, or all the men over 50, if they all need these tests at this time, if I write up that protocol and sign it every year, it gives the responsibility to someone else, and there's a much greater chance that it will get done, and it saves me time in the office. Now, empanelment is another thing that IHI and the NCQA talked about to help with efficiency in the office. Most of the offices in the physician network have one or maybe 2 or more doctors in the office that have been around for a long time. They may have 2,000 or even 4,000 patients in their panel that they are responsible for. And if one doctor is responsible for so many patients, there's a much greater chance that things will slip through the cracks. They won't be able to order all the mammograms at the right time, or patients may not be able to get in for an appointment at the right time because that doctor's already so busy. The IHI and the NCQA found that if you close the panel for those busy physicians, that allows other doctors in the office to take new patients that call in and say, I need an appointment, I don't have a doctor, can I get in to see someone? And then if they put it in with a new doctor, that new doctor has more time, they have less responsibilities, there's a greater chance they'll get the right tests at the right time, a greater chance they'll follow up on the tests in a timely manner, and that improves productivity in the office. So it helps the entire office along with helping the patients. Carla?
So another aspect of getting your third next available and improving access is making sure that the care team works down backlog. So backlog, a definition of this would be the work that you are assigned today that you say, nah, I don't have time for that, we'll just do it tomorrow. We all do it. But you can imagine as that piles up and compounds the next few days, you have a lot less availability and a lot less access because you're dealing with backlog from 2 days prior. So it's very important for the care team to try to do today's work today. If a physician's really behind, block time for that physician to get caught up and hit a reset button. Another key aspect is simplified scheduling. So, as you can imagine, if you have fewer appointment types on a schedule, there's more availability and there are more spots to fit patients in because it's less specific. The more specific your schedule is, the more difficult it will be for you to fit the patients in at more, or they will have, I guess, less appointment times that are available to them. It's recommended of a maximum of 2 different types. So this may be as simple as a 10 and 20 minute or a 15 and 30 minute appointment, and that's it. And lastly, supply and demand. If you think about supply, all the resources that you have to see and treat the patient when they come. So this is the providers, the appointment slots, the nurses, the front desk staff, all of the supplies in your clinic. And then the demand is the patients who call in for a visit, all the tasks that come in, patient calls with questions, med refills. And what we found is that the most successful clinics and people in the most successful practices has found a way to match supply and demand. Another thing is vacation contingencies when physicians or mid-level providers go on vacation, to make sure you address the fact that there will be more of a demand when they get back. Make sure your supply is appropriate and make sure you're giving them a bit of a cushion to anticipate that.
So as we've been talking about all these different ways to improve efficiency in the office, we've mentioned a lot of different people in the office. Everyone has a role in the office to help get that third next available down to a very low number, hopefully 0. Physicians need to be able to work with their staff, do the huddle, plan ahead, devise protocols, and for other people to take some of the responsibility. The mid-level, same thing. The nurses and nursing staff have that responsibility as a stakeholder to try and work with the doctor, talk to them, communicate, improve efficiency, get things ready for the next patient and prepare ahead. The front desk and the scheduler, as Carla mentioned, if you're working with the schedule, trying to be more flexible, trying to get the patients in when they want it and not just when it's convenient for the doctor. That helps with the third next available immensely. The office managers have probably one of the biggest tasks because they have to oversee all this and try and make sure that everyone is working together. And then for the whole patient-centered medical home, there's over 150 points that have to be met for certification. And the practice managers, the office managers, it's their responsibility to keep track of each one of those and submit all that information now. So that's a huge responsibility from them. And TPN's administration has definitely a stakeholder, because if we can achieve the third next available appointment, that will help us with the patient-centered medical home certification, which on the East Coast and West Coast is a really big deal right now for getting better reimbursement from insurance groups. And what happens on the coasts eventually happens here. So we're trying to get ahead of the game.
So we've identified, we gave you a definition of third next available, and we identified key aspects that we found to be very important. So you might wonder, how did we do this? What was the method? How did we start, and how did we get to where we ended up? So first we defined the problem. And as we said, the problem was low access, lower scores than we'd like on the CG caps, and a lot of physicians in the network did not have third next available at 0. Next, we decided to look at a provider in our network who's one of my partners, and he's got a full panel, full-time practice. He's been around for a long time, to see what his third next available was. So we set up a way to monitor it in the clinic, and it was actually astoundingly wonderful. We said, wow, so it interested us to know, what is he doing right? So we started to ask, what are people doing in the network so far? Let's get up to date and let's find best practices. We reached out and we called all the office managers of the clinics and asked, what have you found works? What hasn't worked? What's your understanding of a PCMH or third next available? And then we looked at the IHI website and did just some research on our own, and that's how we came up with those key aspects. We also came up with a sample protocol to give to clinics to help them implement change. We engage stakeholders at the PCMH collaborative that the physician network has once a month. We gave a brief presentation kind of similar to this, just to educate them, and then the data that Ash presented to you it shows how much their knowledge improved after their education. We created educational material to go forward for new hires so they can be caught up to date with where we're at now. We have a Learn module that we created yesterday. We have a poster that Salam will show you at the end, and a handout of PCMH definitions. We also, Suzanne and I, went out to the individual offices that are primary care in the network and gave the bare bones presentation just to get them caught up. So,
So the keys to success for this project were continuous improvement, as every project is. Every project is so dependent on not just achieving it, falling back and forgetting about it. You got to keep working on it. So we're realizing that even before we try to achieve it in the process. We want the continuous improvement. Plan, do, study, act. The PDSA is so important here. We gave you the different aspects of it, how to become more efficient, but how do you do all that? I mean, that's a lot of information to throw at an office. It can be very overwhelming. One doctor may practice a little differently than another doctor. Their teams might want to work on one aspect first. So if they do a PDSA and say, okay, let's look at our numbers now, let's try something and see if it makes a difference or not. The whole PDSA is to try and show that small things do help. If they do, let's roll it out. Let's share with other people in the office. Let's share with other offices. This is just the continuous act of, first you think of something, like in my office, I thought, okay, my no-shows are not that good. I really need more people to show up for those appointments that they schedule. How can I improve on this? So I heard from another office that they call their patients the day ahead. Yes, we do have this automated robocall that will call them and say, you have an appointment coming up. A lot of these patients don't recognize the voice and they hang up, they don't pay attention to it. We found that if you call the patient from the office, if my nurse, who my patients recognize, calls and says, okay, you've got an appointment tomorrow to discuss your diabetes with Dr. Vandenhall at 10 o'clock, can you show up at 9:45 and we're going to go over some information. We want to make sure we are ready for you. We want to make sure we have all your questions answered. So if you show up a little bit ahead of time, we can be prepared for you. I'm hoping with my little PDSA that I'm doing this month that will show when my nurse calls them. For one thing, they'll show up on time. For another thing, maybe they'll even show up those 15 minutes early like we ask, and that will help with our efficiency in the office. So I'm going, right now in my office, I'm keeping track of the no-shows for this month. I'm going to compare it to no-shows from last month and see if it's made any improvement. If it has, I'm going to try and convince my partners to do the same and maybe talk to other offices so that they can improve their no-shows, improve their production, improve their efficiency. So this is the whole PDSA cycle. And Carla?
and last but not least, despite all of the benefits we've discussed so far, this slide just shows if you increase your efficiency, we did just rough estimates based on specific CHI data. Imagine if one of the PCPs saw an extra 2 patients per day because they were so much more efficient. Their whole care team functioned better. So there's about 210 working days per year. Times 2 patients is an extra 420 visits per year per provider. And as you can see here, if a nurse practitioner or a PA sees the patient, we're not reimbursed the same as if a physician sees them. So for the network, times about 15 primary care providers, that's almost $750,000 that we would make if we can just improve our efficiency. I know it's hard. People come to us and say, just see a few more patients, and you're thinking, gosh, I'm already swamped. But maybe it won't feel that way if we can get better and more efficient. So anyway, Salam will show you our poster.
So basically what is in our project deliverable. So 3 things stems on educating the care provider about the importance of having the third next available down to 0, and to educate them about certain intervention that was tested and evidence-based to reduce that intervention to 0. So we have a learning module, we have office visits to educate care providers about that, and we have a poster also that we developed. It basically summarizes what the presentation that we went through.
And if the offices have this poster up in their break room, that way if they forget something, if they don't quite understand something, they can always go back to this poster at any time, even after we've been out to have our presentation. Does anyone have any questions?
Yes, Barry?
So, again, some observations and then a question.
Thank you.
I think it's great. I love these two topics. You know, from a patient's point of view, they assume the quality is already there, right? We all went to med school, you're all board certified. It's kind of a commodity to patients. They just assume that's there. So I think the patients, what's really important is how am I treated in the office, patients or the hospital, patient satisfaction stuff, and can I be seen? You know, what's that access? And I think that's really important because we're facing new competition we haven't before. These minute clinics are going to thrive because it's just about access. You know, and you're going to see you know, Walmart, CVS, all these kind of people providing access that we traditionally haven't. Also, you're going to see in Omaha this Think Health, you know, this clinic that's being put out, 150,000 square foot building, all the services under one roof, hours 7 to 7. So there's access. So in competing for patients, I think having that, if people can't get in to see their doctor, they're going to move on. So I guess my question is just with all the variability in the practices, is that where, you know, these 6 elements that you found that I'm guessing improving that with various providers will come from various sources? Is that kind of behind those 6 elements? Or
It's
how to
basically,
spread that to the other practices?
right, so the Learn modules and all of the education we created is something that could go forward. But basically, hopefully they can learn or go through those aspects, learn about them, be able to analyze their own practice and develop their own sort of a protocol. And we, like I said, we have a sample protocol that they could look at just to get ideas of where to start even.
Thanks. I have a follow-up question too. Do we need to retrain our patients a little bit? Because I'm guessing in the old model, they may not even know they can get in the same day. You know, do we need to retrain them a little bit? That, gosh, we're really intentional about this. If something comes up, call us, we can probably get you in.
Or
today
advertise
within
same-day
24 hours.
access available. They would love that.
The offices that are going through the certification for PCMH have brochures that they give to the patient to re-educate them. And maybe putting a sign outside saying same-day appointments available. A lot of our competitors are doing that. I know some of the offices in TPN are doing that. I think that would be very good for us competitively, help with production, all of that.
But it's interesting though too, that one of the drivers for this change is something that Ann kind of mentioned too, the transparency of
Yeah.
what clinic is where, because nobody's going to want to be on the bottom tier of that box. They get competitive.
We're used
So
to all being
they're gonna
good.
start- Yeah, they're going to start looking at the rules of how to get better because they don't want to get bottom. So it's the same one.
What are the questions?
So how can we apply this thing in a specialty clinic? I have 4 weeks of waiting to see me, and patient cancel 1 day prior to appointment, and it's very difficult to fit in 3-4 people. That's too much work for the front office and everything with a limited staff. And if you advertise, it's available same day appointment, 10 people come and stand there. That is a conflict.
Your demand is way out of proportion to your supply. What's your one big problem?
But you can use a lot of these 6 steps, concepts that we were discussing. If you do your huddle ahead of time, you can check and see, okay, I've got this patient coming from Dr. Vandenhollen. She never sent me a report. Why am I seeing this patient? We need to call Dr. Vandenhollen's office and get records on this patient so that I'm prepared before the patient walks in the door. If you do that the day ahead of time, do your pre-visit, your daily huddle, and look at what's coming up the next day, that'll help you be much more efficient, less wasted time. If you have protocols written up, that'll help to make sure that you're not doing stuff that your nursing staff could do. They could follow your protocol. For every new patient we have to do this, for every other patient we do these things. That would save a lot more time for you. I don't know what your practice is like, but sometimes in panelment, if you have one specialist who's been around forever and everyone in the community knows that name, all the new patients may ask for that specialist, but if you close the practice, that'll help the newer specialists build their practice up, and that'll help with efficiency.
The problem I face is same-day cancellation. And then people try to call, and they come, but they come late, and getting the things is difficult.
And that might be where one of those PDSAs come in, like I'm trying to do in my office right now. If you look ahead and say, okay, these patients are scheduled for tomorrow or 2 days from now, and let's call them and make sure that they still remember, because they had to wait for 2 months. They may have forgotten that they had that appointment. Sorry. So that's another thing that might help decrease no-shows. You might want to try different PDSA cycles just for a couple weeks or a month and see how that affects your no-shows.
Are you guys able to sort of actively manage those cancellations? You know, he mentioned a cancellation. So say a patient has an appointment at 11 and they call to cancel. Can you call someone who's scheduled at 3 and say, gosh, we have this opening, would you like to come in sooner today? Because that opens up an appointment later if you have
Sure.
somebody that calls in with something.
You could definitely pilot that project. It's a great idea.
Just a thought.
We do, but we also do what, we also do, we call a couple days beforehand to make sure they're coming.
Minimize those.
Because, and that has helped dramatically. The thing, I think what's, people are learning that medicine is becoming a team game, vertically and horizontally. And the people who are working under you are going to start to have to realize it is going to affect them. They're going to be found to be the weak link in the system. If they're the weak link, they're going to get replaced. So it's not you probably, it's somebody underneath you is not scheduling right.
Is anybody at TPN doing online scheduling?
Not
I'm
yet.
Thinking
It's-
about how when my haircut person is hard to get into, and when she has an opening, she posted on Facebook, for example, and right away I call because I'm a last minute person. If we got to the point where things were more online and patients were used to going to a web page or something, that'd be a really easy way to communicate last minute openings without calling a bunch of people.
I think that's for October. Barry would
Is that
probably
part
know
of the
better.
Pareto?
Uh-huh.
Yeah, this is sort of coming, and there's a lot of anxiety around it, you know, but it's how you function and everything else.
Cliff Robertson owns, and I think most of us know, several haircutting salons around
32.
the country. 32
Oh, wow.
of them in Oregon and Washington. And you can go on, and I've seen him just go onto his phone, and you can see the wait times for each one on the phone, the map, and that's an app for everyone. And our emergency rooms used to post up billboards, how long the waits to get, how long the wait is for our emergency room, won't come to the exciting things. Really great projects, great presentation. Tell me, how did you pick these? Were these, did you get together and select them, and then how did you decide to be on each of these teams? How were these projects?
We had a list of options for projects, and Dan DeFries encouraged this one, and it has just been dovetailed perfectly with the whole patient-centered medical home that TPN has been working on.
What
So
was the homework that you did prior to this?
it really fit in perfectly.
Yeah,
Made our
both,
job easier.
both projects were well picked. I feel like they're extremely relevant, and that made it a lot easier to really care about what we were doing because it made a big difference.
And Jenny got to be their coach. And so would you, like, any observations that you would have about the whole process that they went through that you were especially proud of, or observations that you have just spontaneously about the experience?
I think it's been, I wish all of you could see the extraordinary journey that the teams have gone, the people, these physicians have gone on. To be able to kind of come in from different locations and different specialties, and to be able to learn how to work together. The things that we in administration take for granted, right? I mean, that's what we do. We learn how to work together, we learn to do these things. And to be able to watch them work through how to set up projects and how to go out and talk to stakeholders and how to learn who stakeholders are. And, you know, this kind of evolution has been really wonderful. So to hear that they were relevant projects that CHI will benefit from. And now the trick is the sustainability. And that's always hard. I mean, it's hard in the best of circumstances. How do we do that as good healthcare citizens? So to me, I think that's been an extraordinary journey, and I'm really thrilled to see both of the groups coming back with something that has a financial, but more importantly, patient benefit and has physician engagement. To see these 14 people really excited about what they're doing, that they made a contribution and difference that helped them, these physicians, to be excited about CHI and be more engaged in the solutions that you want, I think was tremendous. So I applaud all of you for what you've done. This was not easy to dedicate this much time. So congratulations to all of you.
Yeah, and the complexity of both projects is layered upon the complexity of forming a high-performing team. And both of those are challenging at best, that's an understatement. So as you look back on this experience, from a team perspective, is there a particular takeaway that you're going to look back 5 years from now and say, well, what I really benefited from that experience on that team was any particular statement that you would make about your team?
I think keeping all team members engaged and making sure there's follow through. At the end of our phone meetings, we would send emails. This is your task. This is my task. This is yours. This is our goal for the next meeting. And just learning how to keep, it's easy to say, I'm going to do this, I'm going to do this, but learning how to actually keep people accountable to what they say. I'd never done that, and that was really beneficial.
And just perspectives, just working with people with just different perspectives. I mean, I work in a hospital, and I know you work in an ICU, and these guys work outpatient, and we just all do something different, so they bring some different perspective about a patient's life through healthcare that you just don't get to appreciate when somebody's talking about things.
Communication was so, that's it. If there's ever anything that's going to go wrong, it's usually because of lack of communication. And just trying to improve my communication and trying to help other people communicate, that was great too. We learned a lot from Jenny with all of that, so that was very helpful.
Any other comments before we close this one down?
Yes?
I have a question. So I've led a lot of project work. And one of the challenges, especially in the beginning, so my question is, did either team come up with this challenge in the beginning of where you're all sitting around, you understand what the scope is, you understand what the problem is. Did you ever have trouble with just going, I know what the answer is, this is what we're going to do?
Yeah.
And then how did you work through that? Because you're all physicians, so you diagnose and you treat, right? And so how do you work through going, I know what the answer is, before working with the team and really finding out what the correct way to improve the process is?
I'm really quick to want to just jump right out there and start doing something right away. And this was I think we were blessed that they were having the PCMH collaboratives every month. We've already got a whole infrastructure set up at TPN, so we learned to go to them, ask them how we could help them, how they could help us, how we could work together. And I think Jenny really did help direct us and coordinate us quite a bit.
Having a team leader was really great. But again, in the future, when we don't have a team leader, look at what your coworkers and colleagues have done and try to gain insight from that. Normally, you're not the first one to think of it or start it. And sometimes that's a good place to go to.
One of the things that we do from the Physician Leadership Institute is try and equip process, the teams with a process. And so when you want to jump to the last step of the process, which is I know the answer, let's just implement it, we keep coming back to, okay, things like who are your stakeholders? Because your process might be the perfect solution for part of your stakeholder list, but not all your stakeholders. How do you gather that? So there's a game board process that we teach that helps answer your question directly, methodically move through these steps.
I think applause is appropriate for both groups.